Hi, I'm Anthony Morlandt in the Department of Oral and Maxillofacial Surgery. Welcome to this video. Today we'll be talking about oral oncology and total jaw reconstruction, which is a very common operation in our service line here at University of Alabama at Birmingham. It's an important disease for us in the Southeast in particular. When we look at SEER data from the National Cancer Institutes, we see that the average annual incidence, or the number of cases of oral cavity and oropharyngeal cancer per 100,000 population averages about 11.6. On this map, you see certain states in red which have a much higher than average incidence. And Alabama, here in the Southeast, is fairly high at an average incidence of 13 cases per 100,000 per year. In recent years, we were ranked as number 1 in the nation. We're currently number 5. And if you look at Alabama by county, you see that some counties are up to 20 cases per 100,000 per year. That's almost twice the national average. What is it about Alabama, about the South, and in particular about these specific counties that make patients more susceptible? In the past, oral cancer was a disease primarily of men, primarily of smokers, and particularly of those who both smoked and used alcohol, such as hard liquor. There are certain sites, such as the lateral tongue, the floor of mouth, and the hard palate, which are at much higher risk than other oral cavity subsites. But most recently, we've seen oral cancer afflict not only older men, older smokers, but younger females, young Caucasian females in particular, between the ages of 20 and 45. This is different from the HPV or human papillomavirus-driven diseases which affect the oral pharynx, or the posterior portion of the mouth, and even the throat, leading into the upper esophagus. But these are due to some specific genetic polymorphisms. They're not tied to the specific etiologic agents classically associated with oral cancer. Again, classically, we've seen more cases of oral cavity cancer among patients in their 60s and even 70s, but now we're seeing that shift dramatically to the left, where younger patients are seeing tumors at an earlier onset, and these, again, are individuals without classic risk factors. So what can we offer patients in the 21st century at University of Alabama at Birmingham? Well, let's talk for just a minute about oral cancer and how it's treated. Many times when a cancer affects the oral cavity, it can invade around the roots of teeth into the medullary space of the bone supporting the individual teeth. And it's a fairly interesting dynamic relationship between the root of a tooth, the cementum making up the root of the tooth, and the periodontal ligament, which binds the tooth to the bone and helps absorb the impact of our chewing forces. That periodontal ligament provides a highway for the transportation of cancer cells down into the medullary space. So it's incumbent upon the ablative oncologic surgeon or whoever's first evaluating the patient to make sure that we understand which jaws, which patients have medullary space invasion, cortical bone invasion, that lining surface, more dense bone, and therefore would need a composite resection or a segmental mandibulectomy, where we remove not only the teeth, but the supporting jaw structure as well. In the past, this was done without much opportunity for reconstruction. So here's an example of a patient from over 100 years ago treated around the time of World War I who suffered a high-velocity ballistic injury to the anterior mandible, where he lost both soft tissue of the external face. He has no mentum, as you can see here on the upper left. He has no floor of mouth and no lower teeth. So through a series of painful tubed, pedicled, vascularized flaps, as you can see here on the lower left, where Sir Harold Gillies, a reconstructive surgeon from Great Britain, moved tubed vascularized flaps to provide external coverage, there was really no opportunity for definitive jaw reconstruction, and certainly this was many decades before teeth could be replaced in a reliable way. So even though this young man looks fairly whole from the outside, his appearance is the only thing that's normal. His chewing, his speech, and his swallowing are very limited. And when we look at quality of life assays in the head and neck cancer population or in the head and neck trauma population, believe it or not, it's speech, chewing, and swallowing which stand out as the most important factors, and those are ranked much higher than things like cosmesis or even pain control. Over the years, it became clear that various blood supply distributions could be mapped out, and the perforator concept took hold in the 1970s and 80s, primarily out of Melbourne, Australia. Through barium sulfate cadaver studies, perforators were identified, and this was found to supply the perfusion to a particular angiosome of the body. So one area of the skin that was perfused by a single dominant blood vessel that could be then traced through deeper layers to a caliber persistent artery. And through the development of very fine microvascular instrumentation, those blood vessels could be divided, sewn together under microscopic magnification, and the flap, which could contain bone, skin, fascia, muscle, and certainly subcutaneous fat, could be reperfused using microvascular technology. Microvascular surgery is based primarily on minimizing the risk of thrombus formation. And here we see suturing a branch of the external carotid artery in the neck to the peroneal artery in the leg. This is a fibula-free flap. You can see the vessel I'm grasping now as much larger than the branch of the external carotid artery, the blood-supplying artery. And so there's a pretty significant size mismatch that we have to overcome. We tend to use interrupted sutures and fine microvascular nylon suture that's 9/0 or 8/0 in dimension, in diameter. We also use a needle that's the size of a human eyelash, so very fine, very delicate technique. And again, we're trying to minimize the risk of thrombus formation, so we use things like heparinized saline in the operating room, and very fine instruments, very highly polished instruments, and a careful attention to minimize tissue trauma. The overarching theme of all of the reconstructive surgery we do, and that's really the main theme of today's talk, is to maintain a delicate balance. If we borrow tissue from one part of the body, we have to preserve that donor site form and function. And so if we take tissue from the arm, if we take tissue from the leg, the rectus abdominis muscle, the deep circumflex iliac artery with a piece of vascularized ilium, the scapula, any of these potential donor sites we choose to use, we wouldn't want to cause such morbidity that we harm that patient in terms of their long-term function. We balance the donor site morbidity issues against the needs of the defect, as you can see on the right side of the scales, whether the wound can be closed primarily, systemic issues such as diabetes or smoking, local factors in our world such as radiation therapy, saliva, and even the risk of infection in the oral cavity, which is laden with bacteria. And we're considering these factors over the theme of form and function, maintaining the very best form and function for this patient for their long-term quality of life, especially as it relates to speech, chewing, and swallowing for head and neck cancers. In the 1960s, new techniques were introduced by Hugo Obergäser, a Swiss maxillofacial surgeon, who first described intraoral osteotomies, that's cutting the bone to reposition both the upper and lower jaw. That was done primarily for growth deformities, and it's a very common operation done today, primarily in conjunction with an orthodontist. And the interesting thing about what Dr. Obergäser introduced was this concept of minimizing extraoral visible facial incisions. So by making incisions inside the mouth, he could make significant changes in the appearance, the position, the function of the facial skeleton. That really hasn't been done much in head and neck surgery. When we remove tumors, such as this patient with an ameloblastoma, a very aggressive but benign jaw tumor that tends not to metastasize, we make larger neck incisions, just as we would to perform a neck dissection or to do an extraoral approach to the mandible for mandibulectomy. So large facial incisions, and in this case use a plastic 3D patient-specific guide that can then be screwed to the mandible and cutting guides placed, which then assist in generating a mandibulectomy specimen. The problem with that is it doesn't really follow those principles introduced by Dr. Obergäser and others over the past 50 years, that if we follow good cosmetic principles and hide incisions in the oral cavity whenever possible and in natural skin creases whenever not possible, for extraoral incisions, we can offer the very best outcome for these patients. And it's interesting in our world of head and neck surgery and maxillofacial surgery that so many of our cancer patients are presenting at a younger age and with more cosmetic concerns and really more of a demand to be made whole again after their surgery. So we're really working hard to provide that service for our patients. Here's an example of a patient with a high-flow arteriovenous malformation of the left forehead, and by hiding an incision in the eyebrow crease along a previous scar, we can make almost a minimally invasive approach to this lesion. And afterwards, here you see on the right, she has almost no evidence of the surgery, no evidence of the scar, and of course no facial nerve morbidity. Jaw reconstruction is complicated. It helps to understand by looking at schematic diagrams like this of the mandible. So here we see the mandible, the molar teeth, the premolar teeth, and a canine. Here I've drawn in a tumor. It can be benign or malignant. It destroys the mandible by invading into the medullary space, as we talked about before. When we resect these tumors, it's typically with 1 to 1.5 centimeter margins for our epithelioid tumors, and for cancers like sarcoma, we choose sometimes even larger margins, up to 2 or 2.5 centimeters. But in this case, we'll draw something like an inverted L osteotomy to maintain that wide 1 centimeter margin, and anteriorly maybe measure here with a good clinical and radiographic margin. Now with this mandible resected, we have quite a large continuity defect that needs to be reconstructed with not just non-vascularized bone, but with vascularized tissue. And as you can imagine, with no jaw and no teeth, there'll be very limited function, nothing for the tongue to attach to, and nothing for the food to contact as it's traveling into the oral pharynx to begin swallowing. So now with this large defect and the use of microvascular reconstruction, the fibula bone can be taken, that long, straight, non-weight-bearing bone in the leg, to provide a strut of bone. And if we need to turn corners, for example, in the anterior mandible, or here at the angle of the mandible, we can do a closing wedge ostectomy, remove a triangular or wedge-shaped piece of bone that then would allow that straight bone to turn corners and recapitulate the curve of the facial skeleton. So with that nice straight piece of fibula bone in place, it's then secured using a titanium plate and screws. And this follows those same reconstructive principles that Dr. Obergeiser mentioned almost 50 years ago. So the bone is secured. Now this is not a new operation. This has been done by lots of physicians. Of course, we usually have more than 2 screws on either side of the osteotomy. We prefer 4 because initially this is a load-bearing construct in the sense that the osteotomy site has not developed union. The fibula bone has to then provide osseous union at the junction of the fibula and the native mandible on both sides. So we hope to see this over time. That does get disrupted by the use of radiation therapy to some degree, but we would hope to see a few more screws supporting this. Now in the past, the fibula was placed, when this was first introduced in 1989 by Hidalgo in the Journal of Plastic and Reconstructive Surgery, there was really no mention of definitive dental rehabilitation. But as we're seeing in the younger patient population, individuals who are a bit more concerned and more discerning about their long-term outcomes, we have a role to introduce this cross-disciplinary modality where we bring in prosthodontics, maxillofacial surgery, and microvascular surgery into the same patient population, and these are all provided at one time. So now, with the use of 3D imaging, we can replace these missing teeth in the same day with dental implants. The dental implants are placed directly into the fibula. These are titanium screws. The threads of the dental implants are then, to some degree, invaded by osteoblasts right at the periphery, so that that implant is irreversibly bound to the bone. The titanium itself is not so terribly biocompatible, but it's the tiny dioxide layer on the surface that is recognizable to the body as self. And so these implants are almost never rejected. We enjoy greater than a 95% long-term success rate when placed in typical mandible and maxilla bone. In the fibula bone, the success rate is significantly less, and it's thought to be anywhere from 75 to 85%, depending on the literature you review. So once the dental implants are placed, these are essentially like posts upon which the prosthesis can then be built by one of our dental colleagues. And so we may see a framework that's custom made It takes any number of configurations, and we can add teeth to a framework that's secured directly to the implant fixture. And when the teeth are added, we offer that patient the most definitive jaw reconstruction available, so that this patient, after the very disfiguring process of cancer surgery, can wake up whole. So it's great technology. And so now I'd like to look at a few specific examples and then show you specific cases that we've done here at the University of Alabama at Birmingham in the past few months. In this example, we'll be using a straight shot of the fibula bone to reconstruct the body and the anterior angle of the mandible region. After the fibula is osteotomized, it's brought up to the mandible and used to create a neomandible. And again, that superior-inferior position is very important to provide the right favorable biomechanical relationship between the implant crowns and the implant bodies themselves, which are embedded in the bone. If there's too much distance between the occlusal forces that are on the surfaces of the prosthetic teeth, it can cause abnormal torquing and excessive forces directed down at the interface between the titanium dental implant and the bone, which can lead to necrosis and early implant failure. Here we see an example of that superior to inferior relationship being respected, and we also see that the fibula needs to be in the right contour and the right mediolateral or transverse relationship as well. All of this is done by respecting, or while respecting, the occlusion, the remaining dental occlusion, as well as the proper position of the temporomandibular joints in the glenoid fossa. So we don't want to have a disarticulated TMJ and a displaced mandible while we're plating the fibula. So the teeth actually guide the position of the facial skeleton during these cases. It's the most important part. And as you can imagine, putting the jawbone in an abnormal position, maybe it looks right externally, maybe it has a good cosmetic outcome, but if the teeth don't fit together or if there's an abnormal dental occlusal relationship, it's very irritating to the patient. And for those of you who've ever had a grain of sand between your back teeth, you know just how sensitive that entire masticatory apparatus is. It really can be quite disabling for a patient. So we want to get that just right, down to the sub-millimeter level. And here we can see from a bird's eye view that proper orientation of the fibula with the titanium plate. And in most cases, this is a low-profile plate that cannot be palpated extraorally whatsoever. And in the absence of infection or hardware failure, these plates can stay in situ for many, many years without the need for a secondary retrieval surgery for hardware removal. One nuance in certain plating systems is to use predictive holes which line up both the cutting guide and the final titanium reconstruction plate, which is used to secure the neomandible or the segment of fibula. And here you see these examples where bicortical screws, that means titanium screws that are engaging both the facial and the lingual cortex of the mandible, are using the same pilot holes that were utilized to hold the positioning guide in place. The terms minimally invasive and microvascular free flap surgery have rarely been used in the same sentence when referring to head and neck skeletal reconstruction. Across many disciplines of medicine, a closed technique has demonstrated decreased morbidity. We've seen this in the laparoscopic surgery world and certainly in robotic surgery, and these are widely used across many areas at the University of Alabama at Birmingham. In the dental implant world, the concept of flapless implant surgery reduces morbidity, scarring, and postoperative pain. Natural orifices, such as the oral cavity, can be used to approach the skeleton and in many cases reduce the external scarring and disfigurement that accompanies an extraoral approach. We do ask the question of decreased morbidity. Because the operation is the same, because we're manipulating the same underlying tissues regardless of the approach, do we actually change the patient's need for narcotic pain medication? Do we offer them earlier ambulation? Certainly there seems to be a benefit in terms of length of stay. This is a patient we took care of recently in the oral oncology clinic at UAB Medicine. This patient had a destructive tumor of the mandibular ramus, which extended to the condyle near the temporomandibular joint. Here we see in all three planes of space, this is expansile and destructive, and in fact extended up into the infratemporal fossa and required resection to create a microscopically negative margin. And so on the lower portion of the screen, you can see the fibula free flap with an osteotomy and simultaneous placement of 2 dental implants at the leg to replace her missing dentition. Cutting guides were used. They were previously fabricated and patient-specific. And all of this is done transorally with a 2-centimeter neck incision to approach the blood vessels. And this way, we could resect about 1/3 of the mandible primarily through the transoral route using patient-specific, custom-fabricated cutting guides. Here we see the prosthesis that is delivered in the operating room. It's made primarily of acrylic, an inexpensive material that's used because this is a temporary prosthesis. The holes you see on the occlusal or chewing surfaces of the teeth are designed to receive the dental implants. The holes you see on the lateral aspects of the teeth, or what we would call the buccal surface, are to allow for access to the curing lamp, which will polymerize the resin that holds this entire construct in place. So here's our patient in the clinic 10 days after surgery. She has teeth, she has a healing wound, and as you can see on her Panorex x-ray, she has an excellent alignment of the fibula with a neocondyle that has been contoured to extend up into the glenoid fossa, and both dental implants and a prosthesis. This used to be a 1 to 2 year long process, but now at University of Alabama at Birmingham, we offer it in a single-day operation. This patient presented with an expansile jaw mass. She actually came to see us because she thought she needed cosmetic facial surgery to reposition her lower jaw. On examination, you can see expansion of the mandibular gingiva. You can see that the lingual cortex of the mandible is expanded as well as we extend toward the floor of mouth. And I can tell you these anterior teeth are all very mobile because of the underlying tumor. There's quite a bit of destruction you can see radiographically, and this well-circumscribed lesion was not found to be malignant. It was an ossifying fibroma. And as we zoom in, we can see that almost near total destruction of the lower jaw of the mandible anteriorly has been caused by this destructive tumor. So for ossifying fibroma, we know excision is curative, and enucleation and curettage may be performed, as with other benign tumors, if mandibular conservation is possible, and resection if continuity is threatened, which is what this patient needed. In her case, the cutting guides were indexed to the occlusal surfaces of her bottom teeth. And again, we're using all transoral incisions to resect this destructive tumor. And in the process, this patient, who's highly functional and expects as close to return to normalcy in the shortest amount of time possible, has lost 8 teeth in her anterior mandible. So our goal, using the fibula free flap again, is to provide bone and teeth as well as jaw continuity in a single operation. One nuance about this case is if you look, there is a splint similar to what we use in orthognathic jaw repositioning surgery that's used to index the upper teeth to the new bottom teeth. In her case, we wanted to superiorly reposition the fibula to provide the best biomechanical relationship and the most favorable crown to implant ratio, but not provide a defect that would disrupt her inferior jaw continuity. So we provided a second strut of titanium. This patient has not been irradiated. This is her first operation, so there's minimal risk of plate exposure or dehiscence extraorally. And the goal here is to combine a nice normal contour of the neomandible with the patient's plate that's going to be placed, as this will provide the drape and the support for her facial profile. And later these can be removed if needed. The other goal is to make sure that all of the screws we're placing into the fibula and to the native mandible don't interfere with the dental implant. So this reminds me a little bit of Ulysses shooting the arrow through the head of Axis to prove to his wife that it was actually he who returned from his voyages. We have to line up the implants and the screws and make sure they don't interfere with one another. So here's the fibula raised in situ. The dental implants are placed at the leg. The implants are placed and then loaded with a prosthesis, and then a light cure apparatus is used. In her case, we made a very small 2 to 3 centimeter neck incision and performed the microvascular reconstruction so that this entire construct, plate, bone, muscle, dental implants, and teeth were all provided to the patient in one single operation. Here she is at early follow-up. You'll notice that the occlusal surfaces of the anterior teeth are 1 to 2 millimeters below the occlusal plane of her more posterior natural teeth, and that's to minimize abnormal early loading before the implants have had a chance to fully osseo-integrate. And here she is in occlusion. She's able to speak, chew, swallow, and function, and most importantly, this patient has come out of surgery, a fairly disfiguring operation in the past, feeling whole. Let me take a moment to introduce you to the concept of dental implants. Dental implants are used in major reconstructive surgery, like we've talked about already, but they're also used in patients who lose teeth from cavities, caries, or periodontal disease, or from trauma. And the basic concept you can see here in this wax model, where the teeth are set up. There's a framework that is supported, in this case, by 3 titanium dental implants under the surface, and there are attachments under the prosthetic base. And those are then snapped into place in a way that makes it very stable so the patient can then eat and chew. The configuration varies. It's all custom fabricated by the prosthodontist, custom designed and delivered. Other options include things like individual teeth. So a bridge, in this case, can be mounted to specific dental implants. And so it takes a little bit of engineering to combine the world of prosthodontics and implant dentistry with head and neck oncology and microsurgery. We actually can implant these dental titanium implants into the fibula bone prior to transfer and actually load them with a prosthesis such as this, made out of polymethyl methacrylate or porcelain, so that the entire construct is transferred and that patient has in real time a functioning mandible or a functioning maxilla with titanium implants and teeth. So when the patient wakes up from their long surgery, they actually wake up whole. Microsurgery is possible because of the instrumentation we have. We have very fine-tipped instruments, highly polished instruments to cause minimal trauma to the endothelium of the blood vessels we're suturing together. Here you can see an 8/0 nylon suture. Sometimes we use 9/0 or even 10/0 nylon suture with a fine tapered vascular needle. The trick is to use only fingertip motion to suture the blood vessels together, and again use these very highly polished instrument tips to minimize trauma to the blood vessels. So by sewing the blood vessels together under the microscope, we can establish arterial inflow to the flap by way of the blood supplying artery, and venous drainage out of the flap by way of a recipient vein, typically in the neck or from the internal mammary artery distribution. When joining the veins together, many times we use this silastic venous coupler. The vessel is fed into the lumen of the venous coupler, and the ends are wrapped over the spikes, and when the 2 ends are brought together, we can establish patency of the, from the flap to the venous outflow tract. It works quite well. It is very important to minimize kinking so that there's no turbulence in the blood vessel flow, which can lead to thrombus formation. We may use a sizer instrument such as this, which helps us identify the right-sized coupler and then select the appropriately sized coupler for use in our case. Here's an example of a mandible with an invasive defect. This defect, again, may be caused by malignant disease, benign destructive disease, or even osteonecrosis caused by osteomyelitis, radiation-induced injury, or bisphosphonate-induced osteonecrosis of the jaw. In years past, approach to the mandible would require a large utility incision in the neck by way of natural skin crease incisions. And we still do those incisions often if we have to remove lymph nodes for a neck dissection. But in cases where we don't, it's nice to offer this patient minimally invasive transoral approaches to the facial skeleton. One way this can be accomplished is through the use of very fine, low-profile titanium cutting guides such as these, which are screwed to the mandible by way of intraoral incisions, and they project and direct your reciprocating or oscillating saw in 3 planes of space, just like the wings of an airplane, for pitch, roll, and yaw, or X, Y, and Z orientation. Next, usually by use of a second surgical team, we make osteotomies in the fibula bone. In this case, a single segment of fibula will be used to reconstruct the mandible. And again, our patient-specific guides direct the cut in three planes of space, the X, the Y, and the Z axis, so we can be sure we're providing a very precise, minimally invasive approach to both the head and neck and the lower extremity. Now that the fibula osteotomies have been made, the blood vessel supply is divided, and the entire flap, consisting of bone, periosteum, subcutaneous tissue, and the skin paddle, which would include crural fascia, is transferred to the head and neck for insetting and microvascular anastomosis. Here we can see the fibula bone that's being fixated to the mandibulectomy site using a custom titanium printed plate with titanium screws. The position of the fibula in a vertical plane is very important because next we will be placing dental implants into the fibula and loading it with a dental prosthesis. So we want to maintain the proper vertical height to optimize the crown to implant ratio. We don't want implants that are so far away from the fulcrum point that we impart unfavorable biomechanical forces that lead to early implant failure. So we are always trying to minimize those eccentric occlusal forces. And occlusal forces are stronger and more potentially deleterious as we move closer to the temporal mandibular joint. Just as if you place a nut closer to the fulcrum point of a nutcracker, it imparts greater force and is more destructive. The more posterior we head in the mandible, the greater the potential to cause damage to our dental implant construct.